So hi, and welcome everyone to the Cleft Palate Craniofacial Journals podcast, both audio and by video interview. I hope you're all having great holidays. I'm Pat Chibbaro. I am the multimedia expert, which is funny for me to have a title like that since I'm so not techno-oriented, but I wanted to I'm really excited to talk about this paper, and what's really strange is that I'm actually one of the authors on this paper, which is the first time I've ever podcast something that I am involved in. So I might even jump in and answer some of my own questions, but I'll try not to. Let me just let you know where this paper is. I think it's an important paper, especially for any teams that are considering moving from a model of inpatient admissions after cleft surgery to an ambulatory setting, because I think there's a lot that you need to know in order to make this successful. And I think that's what's so great about this paper is it really talks to that. So it is in the October 2023 Cleft Palate Craniofacial Journal, and it's pages 1220 to 1229, and it's implementation of an ambulatory cleft lip repair protocol, surgical outcomes. And the authors are Jenn Park, who's here today, Ricardo Rodriguez Colon. But I don't know how to pronounce the name. Bakar, is it Bashar? Bashar Chaya?
Bashar Chaya.
Bashar Chaya. Okay, Danielle Rope. I forgot already how to say Danielle's last name, and she was my fellow. Rockland. Patricia Chibbaro, aka me. Pradeep Shetye, David Staffenberg, and Roberto Flores, who is here with us. So Roberto and I, full disclosure, go way back many years. He was my resident, my fellow, my attending, my husband at work for many years at NYU Langone's MyFace Center for Craniofacial Care. I'm really excited to have been a part of this study, and I would love Jenn, maybe, or Roberto, if you want to give us an idea. I asked all the authors, like, why did you want to pursue this research?
Well, yeah, thanks, Pat. So the reason why is because at a certain point in our practice, we started transitioning from inpatient to outpatient cleft lip repair, as you know. But one of the things that I realized in looking at the literature at the time was that although there were some studies that looked into outpatient cleft lip repair, the nature of the studies were such that they were just looking back on patients that had happened to go home the same day versus patients who happened not to go home the same day, or
Right.
there were other publications on large data analysis, but none of it had to do with implementation of a protocol. And in our case, we were pretty much almost exclusively inpatient, and then we made a decision to go completely outpatient, or at least try to, and we ended up being successful in that. And having a change from with a change in protocol and learning from what the outcomes were before and after, I thought was a type of study that had not been done before, a kind of study that I'd want to read if I was trying to understand what a particular change in my treatment plan would be. So I thought this would be an interesting paper to pursue.
Yeah, and I think, having been a part of it, I know that it was in the beginning to make that transition was a little anxiety producing, I think, for us. But I think we all knew that it was the right thing to do, but that for sure, if you're going to do it successfully, you need to have a protocol. And I think and I think you did such a nice job. And I would definitely, for anyone who hasn't read it yet, just to see how to set up a protocol to launch something like this. And I think this is really helpful that you put this in, definitely for other teams that are thinking about doing it. So Jenn, maybe talk a little bit, just give us a little bit of an overview of what of the paper and sort of what you found, and then we can talk a little bit more in detail about it.
Yeah, sure. So just going a little bit more into the logistics, the study spanned from 2012 to 2021 with implementation of the ambulatory surgery protocol in 2016. And in this study, we included all unilateral and bilateral cleft lip patients treated at the center, and basically stratified them based on both their admission status, so whether they got ambulatory surgery or they stayed overnight, and then compared those two groups in addition to the cohort of populations as a whole, both before and after the protocol implementation. I think that sort of analysis and looking at the data that way helped us to look at trends that are global for the center after implementation of a protocol, and then also looking at how well the protocol works for both unilateral and bilateral cleft patients when you are basically deciding admission status based on a set of criteria. So very briefly, the sort of pathway for ambulatory surgery here is a thorough preoperative assessment to make sure that patients and their families are ready for ambulatory surgery, that patients are healthy enough for ambulatory surgery, mainly meaning that they do not have any serious medical comorbidities or airway or feeding problems. And after thorough education, patients and their families show up for surgery. Those that are deemed fit for ambulatory care will stay in the postoperative area for a few hours to make sure that they're meeting the appropriate criteria, oxygenating well, feeding well, not too irritable, and pain appears to be well controlled. And then those patients at that point can go home and then follow up in the clinic a week later. And then I thought what was pretty special about our study compared to other reports on ambulatory surgery that were out there at the time was that we looked a little more into what I would call soft criteria. So in addition to like your typical 30-day outcomes, readmission rates, we also looked at the rate of families contacting the clinic after discharge and how that might be affected by ambulatory surgery. In addition to whether or not patients that received ambulatory surgery required more medical care after discharge, meaning did they have to go see a clinician, did they have to be readmitted to the hospital? And overall, what we found was that use of our ambulatory protocol led to the majority of patients being eligible to receive ambulatory surgery, and most of them do so very successfully. We had, 0 to 2 cases of any patients seeking medical care after discharge, and most of them were for non-surgery related reasons. And the data shows that using an ambulatory protocol significantly decreases the length of stay across both bilateral and unilateral cleft patients without seriously affecting adverse event outcomes. And then interestingly, the rates of families contacting the clinic after discharge are not significantly different based on whether they receive ambulatory surgery or not. And then like an interesting tidbit was that most calls come in at post-op day 2. So that would be regardless of whether or not they stayed overnight. And I think the numbers are very helpful for any ambulatory or any cleft center looking to implement something like this. In our study, after implementation of the protocol, the rate of unilateral cleft patients receiving ambulatory surgery increased from 30% before protocol implementation to over 80%. And then for bilateral cleft patients, that rate went from 10% before protocol to 56% after the protocol implementation, which shows that at a large medical center, more than half of all cleft patients can be eligible for ambulatory surgery and that it's safe.
Yeah, having been the nurse practitioner on this team, and you pointed this out, Jen, in the discussion, is that one of the things that's really important to be successful in ambulatory surgery like this is the preparation that a patient and family goes through, and also being available, and you do mention this, to have communication after the surgery. And I think that involves time, and that's one of the things. And as you know, many of our patients don't speak English. And one of the things that you have to build in if you're going to have an outpatient protocol like this is you have to make sure that you build in the time to do a very thorough preparation, both in writing if needed, certainly sitting down with both the surgeon at, and the way that we did it at NYU was that both, the surgeon and the nurse practitioner spoke with the families to make sure they were prepared. The other thing that I think is really important when you're with families, and I remember many of them were very hesitant to go home the same day. And I know you'll see this, and you've seen this too, Roberto, where they feel very nervous about having to go home the same day. And what we've always said to them is, if you don't feel comfortable, the baby can stay overnight. But what we found is that when they got into the recovery, and and Roberto, you're discharging them, then they're okay to go once they see that they are actually okay. And I think giving the families that option, that comfort, knowing that they, if they don't feel comfortable, they don't have to take the baby home. And so, maybe Roberto, you can talk more about, some of, the issues with, that you found were important when working with these families to get that kind of a successful outcome as an ambulatory surgery.
Well, I would say two things. And one of which you touch upon at the beginning of the podcast, that the communication part's important. And if you're going to change a protocol at your unit, it really takes a communication at all levels. So we had to re-educate our team. We had to re-educate the nurses in the recovery room. We had to educate the nurses in the preoperative area. We had to educate our anesthesiologists, and everyone had to be on board. And change takes some time. And even the way you give, we've noticed in other studies that we've done, and when a child is being recovered, so to speak, for surgery, and they're slated to stay overnight versus go home the same day, they will get, even the way they get their pain medication is going to be different, because a patient who's going to be staying overnight, a nurse might understandably just want a child to be calm and may medicate a bit more, versus if you want a child to go home and you want them feeding and kind of awake, you may be more judicious about the way you use pain medication. So all that at every level is important. And if things have been done a certain way for many years, it really does take time. And if you notice in the way we performed this study, there's a gap in which we didn't study it. We did not collect patient data because that was a transition time.
Right.
I would say furthermore, if you look at the percentage that Jenn has said, about 50% or so outpatient for patients with a bilateral cleft, about 80% patients with unilateral cleft, those numbers now, I will tell you, are close to 90%, or maybe even
sure.
in patients without any other medical comorbidities, because the culture has really, now it's our normal. Now it's the exception to the rule to have a patient stay overnight when following the protocol. So even our numbers now are even better, and our readmission rate is still exceedingly low. Our visits to the emergency room exceedingly low. So there's still even more development even after this publication.
Right. And, I think when you look at the postoperative period, when the patient is at home, I think one of the things that was very important to prevent readmission, either to an ER or to an inpatient unit, was that during the pre-op, we would tell the family that if you have any concerns about how your child is doing, how do they look? How does the suture line look? Or are they feeding enough? Do you think they're dehydrated? That they should call us first. And that is one of the things that I think, and for anyone that's listening to this, is that communication with your families is very important to help in terms of keeping the kids out of the hospital. Because I think in the past, parents were just, if they didn't think the kids were doing well, they would just take them to a local ER, or they'd get readmitted. But what we developed, I think, in the relationships with our families, is that they would call us. And now, where you can, on just with the electronic medical record, where you can go on these virtual, visits, and they can show me the suit, put the kid's face up to the, camera, and we can reassure them that they're okay. Like all the things that we have to do to help keep them at home, But I think it is important for a team that is thinking about doing this to know that it is work intensive. So your team has to all be on the same page about it. And I think that was one of the things that was important with our team, is that we all knew that we had to maybe spend, a bit more time with those families. And the other thing that I wanted to mention was, in talking about families who are candidates to go home the same day, I don't know how much we saw this with our families, but there were some times where, and I think you mentioned it, Jen, in the paper, that there are some social issues. And that's one of the things that we would do as a team before, is to try to sort of predict, knowing the families and even getting input from social work and, others on the team to say, this patient may look physically that they're okay to go home the next day, but there may be this other situation with the family. But I don't know that we saw that much. Did you see that, Jen, that there were many that had to stay in for social reasons? I don't think so.
They were very few. A few patients, stayed overnight because they had concurrent operations, and the other surgical team wanted them to stay overnight. There were, patients with sort of your usual, a little bit concerned for maybe oxygen saturation that is not optimal, or concerns about feeding that stayed overnight. And, I think an interesting corollary or follow-up would be to see if those patients that actually stayed overnight received significant medical care, or if it was just a matter of extended observation. And then I think you bring up great points.
Yeah, that's a good point. I think that's what you would see. And I think, for some parents, there were those who were just terrified at the idea of taking their child home and being the one responsible for their care. And I think that, it goes back to the preparation of those families and assuring them that you're going to be there, that they can do it, but that also that you'll be there for them to communicate with them. And so I think putting in that time on the pre-op side really makes a difference, on the post-op side, or for those families feeling comfortable. Because I know I used to call into the PACU just to see which kids were actually going to go home, and I could sort of predict if there were a few that were worried about it. But I think we all just did the best we could to, for them to have the least stressful experience, because I think that was what was stressful for me when we first made the move, because I had been on the team for many years doing it the way we always did it, where you stay over at least one night and sometimes 2 nights, but I think, we had to get comfortable with it, which I think made it easier for us to help the parents get comfortable, with it. And I wonder, Jen, if you saw was there anything that was surprising in the findings when you took a look at this?
Yeah, you've touched on some of it. I think when I was tabulating through, the parents calling after they've been discharged or using MyChart messaging, I was actually thinking that the timing of this study and the protocol implementation came at sort of the perfect time, where it became really easy for families to contact the team in a way that's not very resource intensive for either party. I filtered through a lot of just short telephone call documentations, or a lot of MyChart messaging, and a lot of the concerns that patients have are, I'm scared to give this much pain medication. Is that okay? Or, I see a little something sticking out. What is that? And they send a picture, and the reply is, that's just a piece of the suture, nothing to worry about. So despite, us reporting about 10 to 20% of patients establishing some sort of contact with the clinic after discharge, most of that contact is, relatively minor concerns like that, where it's very easy to reassure families with just one quick phone call or a MyChart message back saying, hey, that's totally fine. You can give that extra dose of the pain medication, or it's just the suture. We'll see you guys next week in clinic. And I think the timing of this study and the implementation of this protocol fell into a really nice spot in terms of, our hospital having implemented MyChart and encouraging its use with patients and their families.
Yeah, and I think one of the other, just thinking back to the kinds of calls that I would get from parents, it was very much what you said. The other piece was about feeding. They would often worry that their baby wasn't getting enough fluid, or was drinking. What happened sometimes, as you know, after the lip repair, they would drink okay, but then they would fall off. And often I think it was because some of the local anesthetic that was injected, things wore off. And I remember many parents where you would tell them in advance that that was expected to happen, but when it did, they just needed that reassurance call to know that they didn't have to go running to an ER to get IV fluids or something like that. And that's, again, I think it goes back to, following a protocol that involves very good assessment of the families in advance and preparation for what to expect afterwards. So that, the families really felt as prepared as possible to take on that responsibility, because they do feel that if they don't do something right at home, they could mess up the repair. Parents used to say that to me, am I going to do something wrong that's going to mess up Dr. Flores's work? And I would say, no, and just being there for them. So what was there anything that, as you look back, you wished you had looked at and included in this study?
Well, it's sort of, I think what's so nice about this discussion is that it touches upon a lot of things that are difficult to tabulate in data form that
Right.
you would typically see published in a study like this. But this adds so much context to how the experience has changed for patients and their families. And I think discussing, what that immediate post-op period actually looks like and the kinds of calls that we get and how parents are feeling helps paint the whole picture of what it's like for the patients and their families to go through an ambulatory surgery experience. I know the point of our paper was mainly to show that it can be done medically safely, and that a protocol works in a majority of patients being able to get the surgery. But I think the whole other side of the picture is sort of, I guess not patient-reported outcomes, but family-reported outcomes on the experience and whether this is preferable to an overnight stay. And as I presented this study at meetings around the country, I think a big question that I always got was, well, but how do the parents feel about this? And are we doing a disservice by sort of shifting the burden of care onto families earlier, or enhance or increasing the burden of the support staff that you need in your Cleft center to manage all of the calls and counseling and education. And I think a very interesting study that could be done, for us here would be to assess some of those family reported outcomes, both immediately after surgery, at the first post-op visit, or a little further down the line, because these kids get followed for a long time. And it would be interesting to see how parents assessment of their experience is initially and how it changes, and whether they would do anything differently, especially in New York City. There's a lot of Cleft centers that families can choose from.
Right. You know what I was thinking as you were saying this, a lot of the parents, I've gotten feedback from parents whose kids had an ambulatory cleft lip repair, but then when they had the palate repair, our protocol is to stay, it generally is to stay over one night. And I've gotten a lot of feedback from the parents comparing what their experience was when they did the lip repair as an ambulatory and the palate repair where they had to stay over. And it's interesting, because as most of the parents said that it was easier to take their kids home. In the end, it was easier to go home to their own home rather than have to stay overnight for the palate repair. So I thought that was, what do you think about that, Roberto? I mean, just when you think about the post-op for a palate repair.
Yeah, I mean, I would echo what Jen said. I think looking back, and we didn't know this at the time, but it was a missed opportunity not to look at this. I would say anecdotally, in speaking to families, they do prefer patients that I've spoken to, the many families I've spoken to that we've taken care of, they do prefer and they appreciate going home that day when it's safe. And I understand, and we understand how that may be difficult for other practitioners who are used to doing things a certain way to feel as something to be true. And it's up to us as the believers in this protocol to demonstrate its value. So that's certainly an area of future study. I would say another looking back, another detail that I would have liked to add is that there are a lot of centers who are very big believers in doing these anesthesia-based long-acting nerve blocks. We certainly put local anesthesia, and it does affect the nerves, but we don't use these anesthesia-driven nerve blocks. And one of the and it hasn't affected our ability to do outpatient surgery. And one of my partners, who's one of the co-authors, David Saffenberg, who's a very smart guy, his thought of this was that for a child to go home, they have to feed. And think about when you get a nerve block, when you go to a dentist office, how you can't speak, you can't drink, you can't eat normally. And actually too much local anesthesia or too effective local anesthesia when you're trying to get a infant to go home the same day of surgery is actually detrimental to that cause. As long as and we know that our patients are feeding, they're going home, they're not taking excessive narcotics. So we are able to control the pain adequately. But actually we are doing something that a lot of other centers are not advocating for. We're being a little contrarian. We are not using these long-acting anesthetic-based blocks, and we think that's actually good. We do believe and support the literature showing that you do have less need for narcotics if we use these anesthesia-based nerve blocks, but that's not the endpoint. The endpoint for us is controlling adequately and having the patient go home. So that's one detail that if one reads a paper they may miss. We're working on another paper that's going to touch upon this protocol of ours, and we understand it's contrarian, and other people may say no, that's a bad idea, but we are having safe outpatient and consistent outpatient surgery in which the pain is adequately controlled, child is eating through their mouth when they've had their surgery. So I think that's something, looking back, I would have liked to have stressed. It's unless you're really paying attention, you're picking it up in the surgery. But there's something that, as we speak about this more in the future, we are going to make sure that that's a detail, because we realize that that's a major point of difference, at least that in protocols that are followed at least some Cleft centers.
So you are doing some future work then on this area, on this protocol.
Yes.
All right, looking forward to it. So before we wrap up, I wondered if you had any advice, Jenn, as a sort of a newer researcher, for those who are, thinking about doing, something like this, doing a project like this. What have you sort of learned from the process, and what might you impart on people that are, maybe about to start the journey of getting involved in some of this research?
Yeah, I actually learned so much from this project. It was one of the first projects I worked on with Dr. Flores in a very fruitful research year together. And, I think the things I learned from the study are twofold. One, when you're working with such a data set from a long time period, you have to be really intentional about the information that you're collecting and the outcomes that you hope to explore. I will say that this study evolved a little bit from its inception and conception to the data gathering phase. And as we started to look at what was coming in, that's when we started thinking about, well, what is it like when the patients do go home? Do they call the clinic more? That was like a variable that we weren't originally looking at when we started the project, but one that I think added a great deal of richness and depth to the story that we tell through this study. And then second of all, I think the value of speaking with the professionals that are sort of, on the ground working with these patients and families are so important. For me, going through the charts and, even speaking with Dr. Flores, who is mainly responsible for the surgery portion of this whole experience, speaking with you, speaking with some of the other staff in the Cleft Center was really, really helpful in getting a sense of, how patients and their families feel, sort of what we're looking out for, how to drive that experience while still shaping an efficient and safe protocol. And, it really adds a depth to what we're reporting, I think, at the end of the day, instead of just the numbers, the percentages, the hours that they spent in the hospital. You're able to get a much holistic picture at what ambulatory surgery accomplishes.
Well, yeah, I'm really glad that, I got to, help to be involved in it because, I'm really, the frontline person with these families, trying to get them prepared and sort of knowing the ins and outs of them. And it really illustrates why we really work as a team, that, in order to have a successful surgical outcome, your team really has to be on board together. And I think that, I'm glad that you spent the time, sort of delving into that. And I think, the success, part of it is because they were able to have that communication with all of us afterwards, preventing them from, being readmitted, preventing them from, maybe not caring for the child in the way that we wanted them to, or, whatever it was that would help them. I think that, and again, for any team that's listening to this, that's thinking, and I hope they do, read this, think about, meet with your team. It's stressful when you make that change. People are anxious, and it's really because you're worried about the safety of the children. We know that. But, as you said, Roberto, we've always thrived on being contrarian, going out of the box, do NYU. I've always felt like that's what we're known for. And, we take those, we step out of the box and we get, results that, but you do it with a lot of planning and protocols and, and a whole team effort. So, and I'm really glad, Jenn, that you looked at this as you begin your journey as a plastic surgeon, to see that the work that you do surgically really depends a lot too on the team that you're working with. And I'm really glad that you did this. So any last thoughts, Dr. Flores, from you on this?
Well, first of all, of course, thank you, Pat, and thank you for the opportunity and give us an opportunity to showcase the work that we've done here. I think one important thing to mention is that this protocol isn't for everybody. It isn't for all centers, and we do not think it should be universally implemented. New York City is a population-dense area that has an excellent public transportation system. Previous to working at NYU, I was in Indianapolis at Raleigh Children's Hospital. It's a fantastic center. And I would commonly have patients driving 3-4 hours to see me for their visits. And Pat, you know this because you visited me on an occasion.
Yes.
And so an outpatient Cleft protocol in a Cleft center located in an area like Indianapolis, it may not be a reasonable one to implement in a universal manner, because a great number of the patients may be traveling very, very far. So we really want to be clear that we are not stating that this is what everyone should do. We're stating that if this is something that a team is interested in pursuing, and if they believe that it would be of a safe and valued protocol to implement for their patients, then they can and they should do it. It takes time. We believe in it. And it will be a slow change, but I think that's a very important point, because if your patient does live very far, or if there are just certain aspects of the way your hospital works that it isn't something that you are interested or in implementing, that's fine. We do not believe that this is something that should be the way it's done. It's the way we do it, and we are very happy with the results that we are getting.
Yeah, definitely. I just having worked with these families, it's just for them to be able to go home and feel comfortable and know that, that they have our support. But you're right, it has to be very individual. That is very important. So I'm really glad that you brought that point up. And let me just close by, first of all, for anyone who's thinking about this on their team, I definitely take a look at this paper, and it will give you ideas about, and as Dr. Flores said, to really look at your center to see what would work safely for you. But if it's possible for for some of your patients, obviously it can be done very safely and successfully. So let me just read out this paper again, and I hope that you all take a look at it. From the Cleft Palate Craniofacial Journal. It is October 2023, pages 1220 to 1229. Implementation of an ambulatory cleft lip repair protocol, surgical outcomes. And this is from the team at NYU Langone's Maite Center for Craniofacial Care, where I was happy and honored to work for 34 years. And so happy now to be able to talk with you about this great paper. So thank you so much for taking time. I know that you had to get permission, Jen, to leave the OR to come and do this. So thank you for that. Thank you, Roberto, for everything.
You're welcome. Thank you.
Yeah, thank you.
Okay.